Okay, we're going to start on part 2, secondary immunodeficiencies. So if you have any questions or concerns, be sure and let me know. Almost over. All right, so we got to secondary immunodeficiencies. And secondary immunodeficiencies are usually drug-induced, immunosuppression actually being our most common reason. Stress is also common, nursing school. But the major secondary immunodeficiency disorder that we are going to be talking about is acquired immunodeficiency, or AIDS syndrome. There is something called the Arkansas HIV and AIDS report, and I put a link of a website on your syllabus, on your content module and objectives, and you can refer to that. It talks about the Arkansas HIV quarterly report, and they don't have, the last they have up is 2014. But you can go in there and see by your county the number of HIV cases, the number of AIDS cases, and how they're transmitted. So it's pretty useful information. What about mandatory HIV testing on newborns, the impact on women? Because if you think about it, this would first test the mother's status and then the newborns without the actual mother's permission if you're just testing the newborn. So just think about the implications that would cause. There actually has been some lawsuits brought about and some other things and ethical issues brought up concerning this. And you will continue to see further developments as we continue, I'm sure. All right, so first let's start with HIV in children. First of all, make sure you read the blurb in your Pete's book. There is not much on it. It starts on page 894. And so read what's in the Pete's book. But it talks about HIV infection is a leading cause of immune disease in infants and children. And I ask the question, why? Just like your 4-year-old, why? And the reason is prenatal transmission. Most of the kids get it from their mother. So why is the interval then from HIV infection to the onset of overt AIDS shorter in children than it is in adults? And the reason that is because it attacks an immature immune system that's not yet formed any antibodies. So without it not forming any antibodies and the mom's immune system being down as well, it's a shorter transition time from HIV to AIDS. As far as clinical manifestations, there are 4 red flags. Lymphadenopathy, swollen lymph nodes. Hepatosplenomegaly, the liver and spleen are enlarged. Oral candidiasis in the mouth. And then failure to thrive. So I would make sure that I know these. Now you'll also see things like weight loss, diarrhea, chronic eczema, fever, history of recurrent infections, and PCP. That is very common, particularly with children in AIDS. So that is something you want to make sure that you do remember. Okay. Well, what about the classification system? Well, the classification system, when a child is infected, is classified a little different than an adult. And if you look on page 895 in the Pete's book down at the bottom, you'll see there that it classifies it as a category N, A, B, or C, and even an E. The N is if they are non-symptomatic at all, then they get a category N. A category A would be mildly symptomatic, B moderately, and C severely. Now, again, there is a category E, and that's when the status has not yet been determined. So if we look at these categories here in your book, going back to page 895, the top paragraph, it says the CDC has developed a classification system to describe the spectrum of HIV disease in children. The system indicates the severity of clinical signs and symptoms and the degree of immunosuppression. Mild signs and symptoms include lymphadenopathy, proctitis, hepatosplenomegaly, and recurrent persistent infections. So this is pretty much our red flags. And that is considered mild, so that would be a category A if they have those signs and symptoms. Moderate signs and symptoms include LIP and a variety of organ-specific dysfunctions or infections. So that would be a category B. And then severe signs and symptoms includes AIDS-defining illness with the exception of the interstitial pneumonia. Children with interstitial pneumonia have a better prognosis than those with other AIDS-defining illnesses. It says in children whose HIV infection is not yet confirmed, of course, the letter E is given. So this is what they go by in children. Okay? So it's a little different than what they go by in adults. All right, there's something when you're taking care of children you may see. It talks a little bit about this in your book, but not much. It's called Protocol 076. And Protocol 076 talks a little bit about this in your MedSurg book. You can read on page 332 about prenatal transmission. It has become a standard of care. And what they did was did a randomized study. This was back in 1991. And they had AZT, which is an antiretroviral drug, versus placebo. And to be in this study, your CD4 count had to be above 200, so you weren't diagnosed as having AIDS, just HIV positive. And what they found was there were 364 infants in the study, and they gave 180 of them the AZT and 184 the placebo. And they did it at different times. They did it, sometimes they gave it at the start of when the woman was pregnant, and then the intrapartum period, and then gave it to the infant. And usually at about the 14th week of gestation is when they like to start this study. And what they found was that 40% or 25% infection rate in the placebo group, but only 8% or 13% in the AZT group. So that's a 68% reduction in transmission for those that were getting AZT. The mother was getting it when they were about 14 weeks gestation, and then the intrapartum period, the mother was getting it throughout labor, through an infusion, and then the infant got 4 times a day for the first 6 weeks of life. So giving it before, during, and after pregnancy had a 68% reduction rate with those who got the AZT. Now, they stopped this study in 1994 because it did such good results, and actually this has become the protocol and standard of care. Now, the major risk factors in children are, number one, having a mother who's HIV positive. And that's the highest reason. About 90% of children, the way that they contract HIV is through this route. Receiving blood transfusions, not very many since 1985 regulations. And then adolescence, and that's because of the drug use, the sexual contact that we see. Now, unfortunately, this is the 7th leading cause of death in children ages 1 to 14, so that's kind of scary and sad if you think about it. Transmission, it is primarily transmitted via blood and blood products. What HIV likes to do is selectively target and destroy T cells. Remember, that's cellular immunity, thereby decreasing and eventually eliminating cellular immunity. Well, if you eliminate cellular immunity, then you leave the child unprotected. There are 2 strands of HIV. There's HIV-1, that's the one that we find in the U.S. and elsewhere, and HIV-2, which is the one that's prevalent in Africa. Now, it is selective. When it say it selectively targets T cells, it particularly likes the CD4 or T cells. And those are the ones that turn the system on. Diagnostic test, I need you to read over in your book. It talks about the ELISA and the Western blot. The ELISA is the enzyme-linked immunosorbent assay, and the Western blot is also a test that we do. Usually we'll do the ELISA twice because it's very inexpensive exam, and it's very easy to conduct. And then if it's positive, and it's come back positive twice, then we will do the Western blot. And the Western blot's a more specific test for HIV antibodies, but it's also a lot more expensive as well. So what's the problem with testing infant's blood? Well, you're testing maternal IgG, and if the mom's been positive, then you may get what we call a false positive reading up to about 18 months. Now, do some children that are born to HIV positive mothers come out and not develop HIV? And the answer is yes. We've had children after 18 months who did not convert and have HIV after that time. They're looking at a lot of different reasons of why that's happening and trying to figure that out. Again, the Protocol 076 is helping with that decrease as well. Let's see. Medical management with these children is going to be supportive. There's no cure for AIDS, as we know. The common medications that we use is IV immune globulin to help boost immunity, AZT, which is the thing we talked about earlier, the antiretroviral drug, and Videx. Now, these are given 3 months to 12 years. Bactrim and Pentam are also some of the common medications we use. If you remember earlier, I said PCP was the most common opportunistic infection in children, and that's why they get the Bactrim and or the Pentam, whichever one they can tolerate the best. All right. Assessment of children who are HIV positive. Focus on potential sites of infection. Assess their height and weight frequently. Look for candidus infections, particularly in the mouth and the diaper area. Watch the child who's having a lot of developmental delays. That's always a red flag. Assess family support and coping mechanisms, because it's going to take it's going to be a toll on the whole family, because again, usually if this child's HIV positive, 90% of the time they received it from the mother. Their ability to care for the child, and if it's an adolescent, make sure you're educating that they can transmit the HIV positive virus even when they're not symptomatic. Nursing management is primarily supportive for children, preventing infections, adequate nutrition, promoting their respiratory function, trying to prevent them from getting infections, mouth care, using universal precautions, and confidentiality is a must. So you're getting ready to discharge planning for a child who's HIV positive. You always want to start this well in advance. Be very honest and direct. Education is essential, especially for the adolescent period. We do need to let them know that there is no evidence of casual contact spreading the disease. Education of the parents at this point is very important as well. As far as school attendance, they do have unrestricted school attendance. The only contraindications would be lack of controlled body secretions, biting, and open wounds that cannot be covered. As far as changes in the immune system, they will get the inactivated polio vaccine. The pneumococcal and influenza vaccines are still recommended. Otherwise, they will get the regular usual schedule. All right, let's talk a little bit just about HIV in women. It is the fastest growing rate. If you read your box on page 329, it talks about gender health considerations. It's a pretty cool thing. The recognition, we know, of gynecological signs can accompany HIV infection is critical to early diagnosis and treatment. So I've got a woman who keeps coming in with constant PID, pelvic inflammatory disease, and she's had, herpes, and she's had this 4 or 5 times this year. Those are red flags. The woman who comes in with consistent gynecological signs and that they're not healing and they keep coming back. Mortality rate in women is a lot higher, 60%, because a lot of times by the time you find it in women, it is advanced more than in men. Studies do show that STDs are more common, particularly syphilis, cankers, pelvic inflammatory disease, your herpes, your candidus, and your human papilloviruses. So what about the patho or etiology? This was first identified in 1981. We're really uncertain still. Most people are still blaming that African green monkey. But HIV is a human retrovirus, which means it reverses the normal process of transcription. So it carries the genetic material on RNA rather than DNA. And I have put a link up here, and I encourage you to watch it. It is an excellent link over the patho of HIV and how it gets in the body and replicates. At the end of the video, it also shows how all these medicines that I posted on the PowerPoint, how they affect each part of that and where they come into the chain of affecting and disrupting that replication. HIV prefers, we've already said, your T4, CD4. So your T4s are also called CD4s. Your T3s are CD3s. Your T8s are CD8s. So a lot of times you'll see them called CD4s now instead of T cells. Read over pages 326 through 327 and figure 19-3, page 328 as well. All right, so we're getting ready to look at laboratory assessment. If you'll recall, the lymphocyte count was usually 30 to 40% of the white blood count, with the normal ratio of CD4 to CD8s being 2 to 1. So for every 2 CD4s, I have 1 CD8. If you'll remember, CD4s or T4s turn the system on, and CD8s turn it off. Well, and what happens in an 8 patient, because it prefers the CD4 and it kills those, the ratio becomes reversed. So now I have a 1 to 2 ratio. For every 1 CD4s, I have 2 CD8s that are turning it off. So they can't ever turn their system on. It's immunosuppressed. The normal CD4 count's about 800 to 1,000 cells per cubic millimeter in the normal adult. Testing during the window period is also a problem because that's going to provide what we call false results. Now, that can be anywhere from 3 weeks to 3 months exposure to 6 months. So it's however much time that you initially come into infection with the disease and actually develop antibodies. So it may take a little bit before you do that. So if you contracted HIV, let's say you went out to a wild party and woke up the next morning, didn't know where you was at or who you was with, and then you wanted to go get blood 2 weeks later, and you tested negative, so you gave blood, and then it may be 3 months to 6 months later that you actually test positive. So you were in that window period, and so those are the few cases that still get through. Diagnostic studies, again, we do with the adults the same as the children. We start with the ELISA because that detects serum antibodies that bind to HIV antigens and test plates. It's inexpensive and accurate. Then we have the Western blot that uses electrophoresis to separate viral antigens and measure serum antibody reactions to specific viral core proteins. Now, T4 and T8 counts, the problem, we want to check that as well. But the problem with the ELISA and the Western blot, again, is if you test in that window period that I just talked about, then you're going to get a false negative result. So you always want to go back and test someone at different periods, not just one time after they've come into contact. So the motto is, if it's wet and not yours, don't touch it. So let's go to the think tank. And let me get my book out because I've got my book marked. The think tank. What is the window period? And I've already talked a little bit about what the window period is. Excuse me here for just a second while I find my chapter. Chapter 19. Okay. And why is it significant to know about this in relation to diagnostic tests? Again, it's important to know when someone was exposed, because if it was during that window period, they may test false negative when they are actually a positive. So you want to make sure that you are doing a lot of questions and you understand that they still may convert 3 to 6 months later when they start actually developing antibodies. That's when they become HIV seropositives, what we call it. Think tank. Who should be tested for HIV and why? Without looking on page 333, who came to your mind? Most people probably thought, people who are drug users, right? Some people probably thought maybe themselves, if you're a risk. Those who have multiple sexual partners, right? Those who have known sexually transmitted diseases. But if you look here on page 333, it also, the CDC suggests that people who received a transfusion between 78 and 85, because after 85 we started screening, people planning to get married, we used to do that, but we've quit, people undergoing medical evaluation or treatment for manifestations related to HIV, people admitted to hospitals, what do you think about that one? People in correctional institutions such as jails and prisons. And then prostitutes and their customers. So CDC, that's what they suggest, and that gives you something to think about. Don't think we'll ever get some of those tested, though. Think tank. Is there an approved HIV home test kit, and is it accurate? So let's look on page 337. And about 1, 2, 3, 4, 5 down, four paragraphs down, it talks about home kits. And it says there's a newly approved HIV home kit, the Oral Quick In-Home HIV test. And this test uses oral transmucosa exudate. The results are ready in 20 to 40 minutes. The manufacturer recommends the test be performed at least 3 months after an at-risk event. and a positive result indicates the need for additional testing. The manufacturer then provides a 24-hour telephone support system for anyone for general counseling, because unfortunately there's been people who's found that, who freaked out and went through some major depression and other things only for it to come back false results. So you want to make sure they follow up. That's the big thing. Always follow up, okay? If a person has a positive test result for HIV antibodies, it does not mean that he or she has AIDS, only that they've been infected with the virus at that point, okay? So viral loads, talks about those on 337 again. These measure the presence of HIV viral genetic materials that's found in the RNA in the patient's blood. This is also called viral burden testing, and it measures the presence of HIV viral genetic material. These tests are quantitative and indicate the level of viral burden or load, so they're useful in monitoring disease progression as well as treatment effectiveness. Think tank, true or false? The person with HIV infection can transmit the virus to others at all stages, but the recent infected person and those at the end stage without drug therapy are particularly infectious. And the answer is what? True. And the reason they're particularly infectious, if you think about it, is because what? They've been without their medication, if it's been recent and they're not taking their medication, or if it's recent, they haven't been on medication, and if they're at the end stage without their drug therapy covering that, then they're getting their viral loads up. So in both cases here, the viral loads are going up, so they would be considered highly, particularly infectious during this time. All right, the CDC classification is on page 328 in your MedSearch book on adults. Remember, this is a little different than what we talked about with children. This one actually has stages 1 through 4. As far as looking at the stages, we'll look at them separately here. Stage 1 is HIV infection, so they are testing positive for HIV. They have a CD4 or a T4 count greater than 500. Or they have greater than 29% of the total count. But there's no AIDS-defining illnesses in stage 1, okay? In stage 2, again, they're HIV infected, but their CD4 count now is between 200 and 499, and their overall count is between 14 and 28 with no AIDS-defining illness. Stage 3 is an HIV infection. CD4 count now is less than 200, and they have a documented AIDS-defining illness. So stage 3 is when they become known as having full-blown AIDS. Stage 4, HIV infection, CD4 counts. There's no information of the CD4 count, but they have signs and symptoms of defining illnesses. If you would read, we'll talk about this by reading the genetic and genomic considerations on page 329 and 337. On 329, under genetics, it says about 1% of people with HIV are long-term non-progressors, LTNPs. These people have been infected with HIV for at least 10 years and are still asymptomatic. Their CD4 counts are still normal, and their viral load is either undetectable or very low. A genetic difference from this population is that their CCR5 or their CXCR4 co-receptors on their CD4 cells are abnormal. If you watched that video, it showed that HIV virus landing on the T4 cells and connecting up with the CCR5 receptors. So if these people have something wrong with their white cell, that the CCR5 receptor is abnormal, it can't connect to it. So it's a blessing. The mutation actually creates a defective co-receptor that can't bind to the HIV docking protein. Cells then with this defective co-receptor successfully resist the entrance of HIV. People who only have one mutated co-receptor gene ally have fewer normal co-receptors and can be infected with HIV, although the disease progression will be low. So that's a blessing when you have that. Other things it talks about at the top of page 329, it says most newly HIV infections are reported in the United States are occurring in ethnic and racial minority groups, particularly African Americans and Hispanic. So those will be two groups, since that's growing trends, that you would always want to keep that in the back of your mind. Then it talks about gender health considerations. About 25% of newly diagnosed cases are women. In less affluent countries, 50% occur in women. The largest risk factor is sexual exposure. Strategies specifically targeted to reducing sexual exposure of HIV to women may help prevent an increase in HIV infection in that group. It says gynecological problems, especially persistent and recurrent infections, can be the first sign of HIV disease in women, which is what I already told you earlier. So just keep that in the back of your mind. I thought that was very interesting information. Then on page 337, if you go over to there, it talks another thing about genetics and about the HIV genotype test. So that's very interesting as well. So read over that. Think tank. What if the patient is diagnosed with AIDS, their CD4 count's less than 200, then the CD4 count goes above 200 and that opportunistic infection's treated? Does that patient revert back to just being HIV positive, or are they still considered to have AIDS? That's interesting, isn't it? Well, let's look on page 328 under opportunistic infections. It says a diagnosis of AIDS requires that the person be HIV positive and have a CD4 count of less than 200 or less than 14%, and an opportunistic infection. Once AIDS is diagnosed, even if the patient's T cell count goes higher than 200, or if the percentage rises than 14%, or the infection is successfully treated, the AIDS diagnosis remains and the patient does not revert back to just being HIV positive. Now we know. Think tank, true or false? The time from the beginning of HIV to the development of AIDS ranges from months to years and depends upon how HIV was acquired, personal factors, and interventions. And the answer to that is true. It can occur at any time, but if you think about how it was acquired makes a difference, because if it was acquired through blood and blood products, then it tends to transmit a lot quicker. It's also personal factors, how healthy you are, how safe you've been. And then interventions also play a role in that. So how well you've taken your meds and things of that sort. Okay. All right. What is an AIDS-defining illness? Well, if you look on page 329 on table 19-1, it gives you examples and includes several things there. Anything from candidas to cancer, to Kaposi sarcoma, to histoplasmosis, TB, to your PCP, and wasting syndrome. So it can be lots and lots of different opportunistic infections that come along. For the most part, your healthcare provider taking care of someone who has AIDS is not in any danger as far as getting anything extra. If it's a TB related or something, of course, you would wear your mask. Transmission, it's not spread casually or mosquitoes or other insects, not from sharing utensils, towels, linens, all those things that we hear. The three most common routes of transmission are sexual, parental, and prenatal, with sexual being genital, anal, or oral sex, because it's very heavy in seminal fluid. I did post a handout for you, the relative concentration of HIV in different body fluids. You can see in the blood and the semen are the two highest, followed by vaginal fluid and breast milk and amniotic, and then from saliva on down, it doesn't have that much in it. Parental, sharing needles, contaminated blood products, and we know it's heavy in the blood, and then prenatal, it would be placental and breast milk transmission. Signs and symptoms, again, you start out non-specific, kind of flu-like, and then it increases and starts affecting all your systems. You can read on page 344, the chart on 19-3 goes over some of this in more detail. Fast facts about sexual transmission. You want to use your ABCs in this count. It is not airway, breathing, and circulation. It is absenteeism, being faithful, and condoms. It is more easily transmitted from male to female. related to the mucous membranes. It talks about that in detail on page 330. It talks about using certain condoms. It says a latex condom for genital and anal intercourse is imperative. A condom or latex barrier, the dental dam over the genitals or anus during oral, genital or anal sex, and latex gloves for finger and hand contact. It also talks about gender affecting HIV transmission under sexual transmission, page 330. It says, like all other sexually transmitted diseases, it's more easily transmitted from infected male to uninfected female than vice versa. This is because HIV is mostly easily transmitted when infected body fluids come into contact with mucous membranes or non-intact skin. The vagina has more surface area of mucous membrane than the penis. Teach women the importance of always using either a vaginal or a dental dam or female condom, or having their sexual partners use a condom and latex based. And then it goes into talking about sexual acts and practices as well. All right, oral anal sex is the most risky because that mucous membrane tends to tear, and because the risk of the tears, the HIV infection will get in there. Viral loads at the time of intercourse makes a big difference. If you have a very high level, then you've got a higher risk of transmission. Condom use, again, latex, HIV and AIDS prevention to the healthcare worker. There's a chart on page 19-1, page 332, that you need to read over, and it's pretty common sense. Think Tank, is there an effective pre-exposure prophylactic drug to prevent HIV infection in a non-infected person who's having sex with an infected person? See page 330, drug alert on page 332 also. So on page 330 it says there's new research for prevention of sexual transmission that's resulted in the drug use therapy for pre-exposure prophylaxis. The use of the combination drug Truvada by HIV-1 negative sexual partners of known HIV positive people appears to reduce HIV transmission. So now we know. Then it goes over drug alert on page 332. It says pre-exposure prophylaxis does not replace the standard safe sex practices recommended to prevent HIV transmission. Also, if this type of drug therapy is used in patients who become infected with HIV, the risk for developing drug resistance increases. Therefore, remind people who's prescribed Truvada to use the safer sex practices previously described and to adhere to an every 3-month HIV test along with monitoring the side effects of this drug. Needle sticks, what do? Don't panic. If you look on page 332 under transmission and healthcare workers, it talks about needle sticks and sharp injuries being the main means of occupational related HIV infection for healthcare workers, and that healthcare workers can be infected through exposure of non-intact skin and mucous membranes to the blood and body fluids. The best prevention for healthcare providers is the consistent use of standard precautions for all patients as recommended by CDC. So you always use standard precautions. If you've been stuck, you want to immediately notify, of course, wash your hands, and then notify infection control. They will usually test the person who you got stuck by, or whatever the case was, and follow up with that person as far as testing and yourself to see what their status is. Opportunistic infection, you need to review your meds. There's a chart on page 339 on the common examples of drug therapy that goes over the major cases and some of the names of your drugs. You'll see if it ends in the word vir, V-I-R, then or dine, D-I-N-E, or ine. Those are usually common words for your HIV meds. Now, opportunistic infections, like I was talking about earlier, do not pose a threat to the immunocompetent. Remember, that's the person who has an intact, healthy immune system. Caring for a person with HIV or AIDS. Now, if the pathological infection is like TB, of course, it's airborne, and you would want to institute precautions. You can read over the opportunistic infections in more detail on pages 333 through 336. Think Tank, what are the main interventions that will be directed that you will be directing your interventions towards. It talks about these on page 340 through 344. It talks about that you're going to be managing pain. That's a big thing. Enhancing nutrition is a big thing, and you need to read over all these. It's a very good self-explanatory. Minimizing diarrhea, restoring skin integrity, and supporting self-esteem and home care. So just read through those a little bit. Most of it's common sense. All right, that's the end of this session. If you have any questions or concerns, let me know. You can email or text me. Lots of material to review from the book on this one as well. And I've went over most of the things that are very important and read a lot to you. So make sure you're reading your material. And if there's anything you don't understand, you contact me. Thank you and have a good evening or day or morning or whatever it happens to be for you.